Hello everyone, my name is Tina Harden and I'm the Executive Director of Clinical Informatics and Innovation at the Commission on Excellence in Innovation and Health, or the CEIH for short. Welcome to today's Improvement and Innovation Showcase, Clinical Registries Improving Care Through Quality Insights. First of all, particularly important in this NAIDOC week where we are celebrating 50 years of Deadly, I would like to acknowledge that the land that I am on today is the traditional lands of the Kaurna people and pay my respects to their spiritual relationship with their country. I would like to acknowledge the Kaurna people as the custodians of the Greater Adelaide region and recognise that their cultural and heritage beliefs are still as important to the living Kaurna people today, and acknowledge any other people online today, either Aboriginal or Torres Strait Islander, or the lands in which you are coming to this virtual meeting on. Right, on to the important things. So today is all about clinical registries. Clinical registries play an important role in improving healthcare by collecting and analysing patient outcomes. They help clinicians and services understand where care varies, compare performance, and use these insights to improve care over time. That's why clinical registries are a key focus within the CEIH's priority focus areas on data-driven clinical decision-making. This again reflects our commitment to improving how clinical registries are developed, connected and used across South Australia. This is our fourth episode in the series, and this session introduces the Clinical Registries Project, the priority focus area I mentioned before, and its role in strengthening how data is used to support care across South Australia. And it really starts to help us paint a strategic roadmap for the system and some core deliverables, which Stephen will talk about. So, introducing Professor Stephen McDonald. Stephen is a nephrologist, a clinician researcher and director of the Adelaide Epicentre. He is, I'm going to say, Stephen, a world-recognised global leader in clinical registries, certainly well recognised in Australia, having led the Australia and New Zealand Dialysis and Transplant Registry for over 20 years. He co-founded the SAMRI Registry Centre, so the South Australian Health and Medical Research Institute, and has helped advance registry-based research and clinical trials. His work focuses on using health data to improve patient outcomes and healthcare delivery. Welcome, Stephen. A privilege to work with you. Over to you.
Thank you, Tina. Thank you for those very kind words of introduction. Thinking around this session was very much as a bookend, and some of the themes that come up will directly reflect those that were brought up by Tamara and the Salin team in the first session last month. In the meantime, though, I guess what you've had is really some fantastic snippets of what's possible and what are the critical issues about registries, and the discussion around Indigenous data sovereignty and the incredible importance of making sure that you count everybody. You can't just count the people that are in front of you. You need to make sure that you count everybody, and that the mechanisms you use to count people are you know and understand the biases. And you also heard from Sangha Baratney about some of the things that are done in Northern Territory. Yes, Northern Territory is smaller. Everybody knows everybody more so than in Adelaide, but equally so, it does illustrate, pardon me, what can be done if you're prepared to be a bit innovative and join up some systems. And then, of course, in the last session, you heard some different approaches, but what a larger, mature system can do, and in particular, ANZICS, the ICU registry, is almost as old as ANZ data, but is one of the large and world-leading clinical quality registries. So what I was going to do today is run through run through some issues about what's been going on nationally, what the situation looks like here in South Australia, and then try and bring them together to thinking, okay, well, where are we now? And more to the point, where do we need to be and how are we going to get there? Why, though, should you worry about this? Well, if you are working for SA Health or working elsewhere and involved in healthcare, particularly healthcare delivery in a hospital setting, you're almost certainly dealing with conditions that are included in some way, shape or form in a clinical registry, and probably in a clinical quality registry. You're almost certainly using an evidence base that's informed by a clinical registry of some type or another. And all of those conversations that we as clinicians have every day with patients about what's going to happen to you, they can be, or they should be, informed by data from a clinical registry, because the key questions are about what are the chances of me living to go home after my coronary artery bypass surgery. What's the chances of me being able to be not in a nursing home 3 months after my hip fracture? Now, that's data that's available. It's only available because we have clinical registries. I have used the terms clinical quality registry and clinical registry interchangeably there, but just to emphasise the point that Tamara made a few weeks ago, that the defining feature of the clinical quality registries, which are a subset of clinical registries, is that maturity of organisation, that provision of feedback to clinicians and to healthcare providers on their outcomes, their clinical results. So as a clinician, the information that we get from clinical registries, from clinical quality registries, is incredibly important. If you're not working at the coalface, if you're working elsewhere in the organisation, they are still relevant. And this is, I guess, a summary of why. This is what we are all supposed to be doing as healthcare providers. These are the National Safety and Quality Health Service standards. These are not nice to do things. This is actually what we're mandated to do. If, as an organisation, we are actually going to perform against these 6 metrics, we need to have a mechanism for doing it. In many areas, we have some sort of a mechanism, but in many areas we don't. And in most areas, and certainly in areas where there is a clinical quality registry, it is very straightforward to report against each of those things, to understand what is the access to healthcare like, how does that vary between where you are and elsewhere, what are the outcomes like, what are the risks, how can you address those. So this is some of the core information that registries provide. That information can't come from administrative data sets. Administrative data sets can tell you what your length of stay is. They can tell you how many x-rays you were ordered, but they can't give that information about more detailed outcomes, and they certainly can't give comparative information across different healthcare providers in the way that registries can. I did want to spend just a moment or two, though, talking about what is a registry and the various types of registries, and that's going to become very relevant as here in South Australia we try and roll out processes and procedures around how we categorise and deal with different types of data collections, because at their core these are all data collections. They're collections of data about people, and there's a whole lot of things that go with that, of course, particularly around protection of people's privacy and respect for their wishes about the use of the data. If you look at the dictionary, what a registry is it's the home of a register. What a register is of course a simple list. It doesn't have to be a healthcare list. Your computer has a register of programs that sits within the registry, and the Windows aficionados sometimes go and fix that. In the healthcare world, though, the registries are divided into population registries, and many of us would have heard of the various the traditional cancer registries. There are other population registries, for example, that record how frequently there are congenital birth defects and so on. And these are registries that actually are very useful, but they tell you how often something occurs. They don't necessarily tell you what happens. So we can understand how often a lung cancer occurs in South Australia. We can understand how often a baby is born with a cleft palate, but we don't know what happens to them. We don't, and that's the population registry side of it. And often, but not always, they will have a legislative framework around that. There are many other clinical data sets which, as a healthcare system, we routinely collect, some for operational reasons, some for safety and quality reasons, some for research reasons. Many of those might be called a registry, but the key concept I wanted to reiterate is in the middle group, there is this group that Tamara highlighted in her talk about these entities called clinical registries and what the distinguishing characteristics are. And you can, as a reminder, I popped a couple of Tamara's slides up there on the screen. Within that group of clinical registries, there are three main groups. There are device registries, there are device or procedure registries, there are condition or disease registries, and there are health service registries. And within those, there's obviously a little bit of overlap sometimes between those broad groups. But within those groups, you can then categorize almost all of the clinical registries, and the particular characteristics about them are, of course, that they're ongoing. As data collections, they tend to be broad but not deep, and that's important because that's what you need from a registry. You need something that's feasible to be done in an ongoing way with as little impact in terms of workload as possible. A clinical quality registry, as I said earlier on, is a really important subset, and typically quite mature registries that have good enough coverage and good enough data collection to provide meaningful reports back to providers. And as I said earlier on, effectively healthcare, as in a healthcare system, healthcare is about access and outcomes. You need to be able to access the healthcare at the right time, and you need to have good outcomes. And if we get, as a system, if we get that right for every patient, then we'll be well on the way to actually achieving some excellence in the system. Importantly, though, one of the things that's happened over the last few years is that these definitions are now quite standardised within Australia. Taking another step even further back, I guess I was asked at a meeting a month or two ago, why do registries still exist? And it was an interesting question because it's something that I'd always taken not quite for granted, but I was a little taken aback that somebody would think that they didn't need to exist. But just, I guess, to emphasise the point that I made earlier on, that registries have a key role in safety and quality, informing us what we do. They also have roles in health service planning quite often. So understanding what the trends are in uses of devices in diseases. So, for example, in my area, the dialysis and transplant registry is not just the main, but is actually the only provider of data that tells you, okay, how many people are starting dialysis, and what are the modalities of treatment, and what's happened in the last 5 years, 10 years, what are we going to expect in the future. And of course, by their nature, registries as ongoing, if you like, collections, large and inclusive cohort studies do provide a valuable resource for clinical research. Reflecting these strengths, the number of registries and the spread, but here illustrated here, the number of registries has progressively grown. There was a strong period of growth going from about 2015 through about 2020. The rate of growth has slowed since then, but there are still new registries being set up. And in fact, there are over 150 now listed on the National Commission for Safety and Quality's register. Not all, there are a few of them that are not classifiable, so that's why you'll see that the number here doesn't quite get to 150, but nevertheless, there are a large number of registries here that are registered and listed with the national group. There are undoubtedly a number of more that are not registered. And we heard a little in the introduction about some of the legacy issues here. And I think in terms of South Australia, there's an important contribution that South Australia has made to the registry sector. So firstly, ANZData, the registry that I've been lucky enough to be involved in, was formed in 1977. It was formed here in South Australia. In fact, it was formed at the Queen Elizabeth Hospital. And that's obviously going to have its 50th anniversary next year. And I'm be happy to see as many of you who would like to come to the 50th anniversary Festschrift or symposium in February next year. David Roeder also reminded me once that this was also the year the first cancer registry in Australia was established, and that was also here in South Australia, I believe. So in fact, South Australia has some really strong history and a great track record in this space. But fundamentally, why do registries start? Why do they keep going? Because there is a need. there is a need to collect information, and there is a need to have that information available for use. And that information is the need for that hasn't gone away with the introduction of electronic medical records. What it does rely on, or why registries exist, of course, is that there is a problem, there is a gap that is sufficiently important, sufficiently motivating, so that busy people, typically busy clinical people, actually do something about it. And one of the areas of tension that is always there in the registry space is registries are typically driven by clinical groups seeing a need, going and doing this, and clinicians being clinicians will find a way of doing things through the system, around the system, through the gaps in the system. And one of the challenges we have here in South Australia is, if you like, acknowledging that legacy, dealing with the legacy in a positive way and saying, okay, that's been a very valuable and positive legacy. Our challenge as a health service is how do we build on that and actually take advantage of the work that has already been done and is already being done, and not crash the plane while we're trying to fix it while it's in the air. There's been a lot of work nationally over really the last 10 years. The pace of that has picked up, but it's been going on, in fact, for 20 years. And underlying that is some recognition at a national level, and in particular at a federal government level, of the value of registries and clinical quality registries in particular to the health system. Tamara mentioned briefly in her presentation the fact that as a country we actually have a formal policy around clinical quality registries, and associated with that we have a program that's now just going into its 4th year, and there's as you would expect, there's a review underway of that program, but there's a clearly articulated policy that the government has out, and if you can see what the aim of this is, it is maximising the value. It's a really interesting choice of words. Underlying that, I guess you say, well, why do we need to maximize the value? And the answer to that for me is we're already investing as a health system. We are investing whether we know it or not, whether we've decided to do it or not, we are invested here. The challenge is how do we utilize the value? At a national level, there is a series of fundamental documents, if you like, the infrastructure that supports registries, in particular national registries, and provides some strong guidance if you want to set up a registry and host a registry. The framework that was released in 2024 really pulls together a number of previous documents around the strategic and operating and technical principles for the clinical quality registries. And Tamara mentioned some of the issues, some of the areas around governance that are in that. There's a bunch of stuff there around technical stuff. There's a bunch of stuff there around, if you like, operational things. How do you identify an outlier? How do you report send specific results? All of that. It's really a very impressive document. And if you are looking at setting up a registry, or if you're involved in a registry in running and hosting one, and you haven't read that document, then you should do so. So that was released in late 2024. That's not the end, though, of the Commonwealth's program, and there's a clear trajectory going forward. As the strategy moves on, and where we are at currently is piloting the self-accreditation and looking at how that's going to work in reality. So part of the framework is defining not just what a clinical registry is and a clinical quality registry, but also putting some degrees of maturation, whether registries are just starting or evolving or fully evolved. And there's a series of criteria to allow you to judge that. And the intent for this is very much to allow registries to move down a maturation framework or up a maturation framework, or move through perhaps a maturation framework, and identify the areas where, for example, their governance or their technical abilities or their data collection may be at various levels. That's helpful for registries, but it's also going to be really helpful for people who work in health systems, because what it will then facilitate is categorization of saying, okay, this is the box that you fall into now. Why is that important? Because as a health system, we are going to need to make processes that match those boxes, so that a mature clinical quality registry can be treated one way, data collection that is at the most an immature clinical registry will be treated quite differently. So the key message here is we don't need to reinvent the wheel. We don't need to reinvent those definitions. We don't need to reinvent those maturity frameworks. They're already done. That's work that I've been involved in. That's work that Tina's been involved in. That's work that others in South Australia, John Beltrami, has been involved in. So it's not a surprise to anybody. Beyond that, there is a clear longer-term vision, and not just vision, but strategy for where this sector is going. And there are plans, and the challenge always is the funding and how quickly they happen, but there are plans for, if you like, seeing all the elements joined up. So there have been discussions grumbling on for a number of years about how we're going to address the issue of the data governance paradigm at a national level. There are certainly some challenges at a state level, but at a national level, whether registries as a whole should still sit within the HREC, the ethics system, or not. There's a bunch of work around interoperability, and many of you might be aware of some of the work that the Digital Health Agency is doing, and in particular some of the work that's already occurring here in Adelaide, Arden, and which Nicole Pratt leads around development and implementation of common data models, so that various data sets can essentially speak to each other or be analysed. And then there's the bigger challenges of how do we get data in and out of electronic medical records. I'll speak a little bit more about that later in South Australia. And then there's that really big picture element that says at a national level, can we start to join up PBS, MBS, yada, yada, yada. So lots has been happening at a national level to create the frameworks. Where are we up to in South Australia? Those of you who know the area north of Adelaide might recognise these are the silos at Owen, just in the Adelaide Plains. It's a metaphor, of course, and it's a metaphor for our health system. We're all working in silos. We're all trying to do the same thing, produce wheat, make people better, but gosh, we're not really connected at times. That's particularly true, I think, of the way the system deals with registries at the moment. There's really not a lot of consistency between DHW and individual LHNs around how we deal with them. Some LHNs deal with registries in a safety and quality framework. Some deal with them in a research paradigm. Some, I'll put my hand up and say, Callan doesn't really know how to deal with them. And we're trying to work that out. So there's that lack of consistency, and there's certainly from the registry perspective, that's a really frustrating thing, because you go to different hospitals in the same system and you get different answers to the same question. That should be an easy thing to say, because there's actually no difference between the patients at Flinders versus the Royal Adelaide versus Lyell McEwen versus anywhere else in terms of how we should approach them in registries. Furthermore, there's actually no mechanism for the information that comes out of registries to consistently feed back into either an individual hospital or a health system more broadly. There are some exceptions to that, and women's and children's have a better system than most. But it is true broadly that we invest a lot of time and effort in putting data into registries. Typically, reports about clinical performance might come back to an individual clinical unit, but there's no particular organised way of identifying issues within hospitals or across the system. And then in the even bigger picture, there's a question about, well, where is the broader issue about data governance, not just about registries, but data governance within SA Health and LHNs? Why don't we have a functional data governance policy in 2026? I don't know, not my lane, but it's a question worth asking. Why don't we have a secure data repository that's functional and available to people outside 5 years, 6 years, 7 years after introduction of an EMR? So the point that I'm belabouring here is that South Australia is pretty fragmented, and there's lots of gaps, and those gaps also provide opportunities to do better. At the moment, there's a lot of activity going on. This is data that was described as dodgy, and it is dodgy data. it's dodgy data. It is the best that's available. And the reason it's dodgy is that people don't know what's going on. So a few years ago, Taryn Besson and Jerry O'Callaghan did a survey within Callan and published the paper that you can see on the right. And last year, Taryn spent a lot of time trying to go back and update the survey and just try and ask people in the metropolitan LHNs, how many registries did you participate in? And we tried to cross-classify them into registries that were listed on the Australian Register of Registries. And there's a certain accreditation, if you like, or certain process to get there, which says which would allow one to say they're probably genuine registries. And then there's a bunch of other data collections that were called registries, and the numbers are there. There are ranges for some of the numbers because there are registries that, for example, we know that a hospital contributes to, but the head of unit didn't report. So it's a real schmozzle out there. What we do know, however, that is that the numbers are large. There are a lot of registries to which we as a health system are contributing data. Are we getting information back from all of those registries? I don't know. I would hope so, but there's no mechanism of checking. What is the process around, if you like, identifying and making sure that the data that goes out is going out in an approved and secure fashion? We don't have a way of knowing all of this. So this is the challenge, is how to wrangle this system in a way that's going to maximize the value of the work, the impact that's being put in. The way I see the registry system is it sits sort of here in a silo, and as registries tend to talk to clinicians because the major stakeholders tend to be clinicians. Clinicians talk to hospitals, but the registries don't talk to hospitals. Hospitals talk to the health department. The registries don't talk to the health department. Clinicians, including me, try and avoid talking to health departments too. National registries tend to actually talk to the Commonwealth because often the funding comes from them, and certainly, as I said, there's been that strong thread of activity from the Commonwealth. But you can see here the problem. There are all these silos, and in particular, this group here, don't talk to this group here, don't talk to this group here automatically. We need to make mechanisms to do that. On the plus side, there is enormous strengths, not just the historical legacy strengths that I spoke about earlier on, but there's actually enormous strengths sitting here in South Australia, sitting here largely on North Terrace. There are major sources of expertise based here. I mentioned the dialysis transplant registry. That's just one of them. You heard from Rosa in the previous session. There's the National Joint Replacement Registry. There's the TAVI, the transcatheter aortic valve implant. There's a National Corneal Graft Registry. There's a variety of things. There's a whole SAMRI Registry Centre that Tamara mentioned very briefly that has not just a collection of its own registries and associated registries, but actually does a whole lot of stuff around pushing registry science. And then there are other registries that are, if you like, based in South Australia, but feed up to the National Registry through a federated model. So we have a trauma registry, we have a coronary angiography registry, we have a prostate cancer registry, all of which are based in South Australia and other South Australian component, but are strongly related. And we also have very strong representation, and Paul Seckham is a great example of that, somebody who is driving a lot of stuff in the National ANZICS registry. Even though ANZICS is based in Melbourne, we're having a strong impact here from South Australia. So we do have an enormous amount of specific registry strength. And we have around that those related strengths I mentioned Arden a moment ago. We've got the AIM, or the Machine Learning Institute at the university, and a bunch of other stuff around there. So that all the pieces of the jigsaw are actually lying on the table if we want to put them together and make a really impressive picture. So what have we actually done about this other than wave my hands and bang on about this? So a couple of years ago, and I say we now, the Commission facilitated pulling together a workshop of a number of stakeholders in the sector. And that led to a submission to HCEC, the Health Chief Executives Council, very early in 2025, I think, and they approved a work plan which had a number of elements. And through 2025 and through to early this year, there was an informal or an interim coordination group which I led, that had some support from CEIH, from DHW, from here from the Epicentre and Summary Registry Centre, and we tried to progress a number of these issues. Unfortunately, we sort of struck the perennial issue in the health system, which is, it's one thing to say something should be done, it's another thing to actually do it, and without specific resources you should do. So that there was some early work and some drafts of a DHW, that is a system-wide clinical guideline around registry participation. There was Taryn's work around the Registry of Registries, and that's really about it. What 2026 has brought us, and I hope this is going to be the catalyst, is the selection of clinical registries as one of the Commission's priority focus areas. So this is a clear message from that the system has heard that, gosh, we need to do something about this for a whole lot of reasons. And that process has been rolling for almost 6 months now, during which time there's been some pulling together of people, but it's now about to hit the road. And when I say that, I'm anticipating that the activity in the latter 6 months of the year will ramp up, and we will start getting stuff done. What is the stuff that we're going to do? Well, we're going to try and make an ideal system. What does that look like? It looks like a system that facilitates participation in registries. It looks like a system where, if you are sitting in a hospital, in a health department, it is easier to work within the system and to participate in a registry than work around and through the gaps in the system. What that will involve is using those criteria that I mentioned earlier on, so that we can identify and categorize registries. And that's relatively straightforward at one level, but it is going to cause some grief, because there will be data collections that people have called registries that we are going to say, without governance, without the ability to bring in other data from other hospitals, it may be a register of something in your hospital, but in reality it's just an ongoing operational data collection or whatever. And then around that, we can then start to develop clear processes to facilitate data governance, agreements with registries, processes about how we identify and prioritize support in a resource sense of registry, how we efficiently use our resources, how we stop wasting time of highly paid clinicians entering data and actually say, okay, why can't we just develop something to pull that from the EMR? And alongside of that, we also need critically to develop those processes so that not only do we do the data entry in a safe and efficient manner, but we actually can utilize the information that comes out of registries to do what we all want to do, which is improve the access to and outcomes of our healthcare system. It's going to involve us all, myself included, in some uncomfortable places, because different places are at very different stages in their trajectory, and we are all going to have to make some compromise. We are all going to have to, I think, accept that we do need some consistency across the system, across DHW and LHNs. It does not make sense to have substantially different processes in different areas. That's going to be tough, because at the moment the system pushes us into our silos. We have empowered quite explicitly local health networks to develop autonomously their own processes. That makes sense if you're delivering health services to your local region. It doesn't really make sense if you're trying to achieve a consistent degree of protection and use of data at a statewide fashion. We need to have solutions that, as I said, facilitate being part of a system rather than working around. And we also need to have real world solutions. We are not going to change the real world of registries out there, the fact that they have different models of CQRs. Some of them are based in the South Australian health system, some of them are based outside of the health system. Andrew Burston in the first session showed you the various diagrams which came out of the Safety and Quality Commission framework. We need to deal with the legacy characteristics. Registries that have been around for 30 years, 40 years have stayed around because they developed tremendous value. So we need to recognise that that comes with a bit of baggage, and you're going to need to accept that and work with that baggage. We also need to have a very clear view about what the future looks like in registries and where we want to encourage and push people. So Rosa, and there are other examples, if you like, of virtual registries. So if all of the information that you need to collect is available in the electronic medical record, then it should be, in theory, feasible to establish a registry by data extraction without additional data collection. In reality, most registries will be some form of hybrid data collection because there will be some need for some sort of niche data, if you like, about the particular characteristics. And a really important area of that extra data is going to be around PREMs and in particular PROMs, patient-reported outcome measures, which we don't have a consistent collection of at the moment. And for many, if not most areas, it's a fundamental part of how we evaluate outcomes of our healthcare system. Actions needed at a number of levels, and I guess in short, I would say that the place, different levels of the health system will have different emphases. Clearly, there's some discussions about policies and procedures at a statewide level. There's some really important discussions about what I've called clinical governance in this table, and that's going to really come home at not just at a state level, but at a hospital level, making sure that those processes are in place. And then there's the human resources and the IT system. So this process, this thinking is going to cut across all of the levels of our healthcare system. How are we going to do this? What are we going to do about it at a really practical level? There has already been some work around developing guidelines in the official sense at the departmental level around, firstly, participation in clinical quality registries, and secondly, about how, if you are hosting a registry, what that looks like. There may or may not need to be a need for a formal policy, depending on how the discussions around the DHW data governance policy evolve. That process is already underway. Things that need to start, and we need to build on the expertise and work of people have already been doing here, is we need to think, okay, who has got processes and where are they up to support and enable participation in clinical registries? How can we build on those and not reinvent the wheel in other LHNs, and to achieve this goal of saying, okay, we want data to go out of the system safely to the right person at the right time, and we want in a secure fashion, and we want information to come back into the right person at the right time. And critically, gosh, it'd be nice to know about that. It'd be nice to have a mechanism so that we could say, gosh, these are the registries we participate in. And this is where having an ongoing so-called registry of registries will be a critical piece of infrastructure to support the processes about participation in registries, to support that data governance process, to support that information, that clinical governance process. One of the no-brainers in all of this is getting some better value out of the investment in our electronic medical record. We need to, there's been some stuttering beginnings of activity to extract data from an electronic medical record. We need to stop doing stupid in our health system. We need to say, okay, the data's there. How difficult is it to extract? We need to make sure that when we develop something in one hospital, that we recognise that other hospitals that participate in the same registry can benefit from the same process. We also need to leverage the community that I mentioned earlier on of expertise that exists around us in the university sector, in the health research institute sector, and build some strong links out to those communities so that we can take advantage of what we already have here in Adelaide in South Australia. At a nitty-gritty level, how are we going to do this? At the core of this all is a CEIH project team, which I'm lucky enough to be involved in. There is a reporting line up to a steering committee, which then ultimately reports up to HCEC. I hope many of you on the call will recognise the expert advisory group, and that will be meeting very shortly. You'll hopefully in the next week or so be hearing about some dates for that. And that's a group that, as the name implies, we are going to be relying on to tell us what we don't know, to say where are the landmines in the field that we want to walk across. That group is by its design quite diverse. It includes clinicians, particularly clinicians with an expertise in registry. It includes people from the safety and quality sector who may or may not have a background in registries. It includes people with expertise in data governance and so on. So those sort of groups, by their nature, can be really interesting because you can learn a lot from them. And as a project, we're going to rely on that group a lot. There will be a number of working groups that are task and time limited set up together with some focused advisory groups, particularly for example around issues of Indigenous data sovereignty and consumers more broadly, that we'll need to set up. But that's what the structure looks like. Despite how the diagram looks, I would hope not too bureaucratic. Why now? Well, I think there's a conjunction of a number of factors. As I said at the beginning, there's been a receptiveness by HCEC, and in particular HCEC Clinical Council, that this is a priority. It is a problem. There are challenges as a state, but there are opportunities there as well. There are opportunities within our digital space as we slowly get going, and certainly there are opportunities to use registry data to improve care and improve outcomes, and there is that national momentum. So that's the positive way to look at it. There's a negative way to look at this as well. We are in incredibly fragmented healthcare, and it's going to be a struggle to try and get people to actually look outwards, because our current processes and structures really do mandate us to look inwards. They force us to focus on our activity levels in our unit, in our department, not what's going elsewhere. We do have a lack of data governance maturity. Interesting, but we do, and that's going to be a challenge. We also have some immaturity in the IT sector, not necessarily in the technical sense, but we have a statewide electronic medical record. That's a fantastic opportunity to leverage things, but there are some critical gaps. There's some enormous gaps in the renal space, which we're not filling. Cancer chemotherapy is done in a separate system, for example. Fundamentally, though, having had a statewide EMR, that puts us enormously in front of the game in terms of the opportunities. But we need to ask how we're capitalising on the opportunities to do this. The current development trajectory, I'd suggest, is somewhat limited. There is a lack of registry awareness beyond the clinical sector, beyond the registry sector, and this is part of fixing that. But I think there's much more work to be done, and in particular, I guess there's a gap between the silo, particularly the safety and quality units in hospitals and registries, that we need to try and fix. And at the last, I said, look, gosh, we have been incredibly well positioned in South Australia to take advantage and lead this at a national level. That opportunity still exists, but it's not going to exist forever. And if we don't get cracking, we're going to get left behind. So what do I think the system look like? The system needs not just to look like that, the system needs to look like this. So registries are directly connected into hospitals. So registries are directly connected into state health department. And we end up with something like this. It's going to be a complex ecosystem. But the ideal is this slight variation on the learning health system diagram, where we have clinical registries, clinical quality registries that provide data. They will identify gaps and opportunities, and we should actually be then using those to say, okay, well, how can we use that to inform doing pragmatic research in the hospital? Perhaps utilising our EMR, perhaps utilising the existing registries and doing registry-based trials. By the way, we have a tremendous track record on that in South Australia. We can then use that to develop evidence-based guidelines. or it may be that we are able to skip this step totally, and then clinical quality registries can then just drive evaluation of performance against guidelines and healthcare practice, and then that gets monitored and around we go. There are some challenges, but there are incredible opportunities for us all, whether you're a clinician, whether you're a researcher, whether you work in a registry, whether you work in a health department, or whether you're a consumer, most important of all. So thank you for your time. Thank you for your attention, and very happy to take any questions.
Thank you, Stephen. That was a fantastic presentation. I feel gave a good grounding on where we've been, where we are, and the hope of the future of where we can go, and the GSD for sure.